And also delayed phase can be added, which is performed 5 to 10 minutes after that to assess urinary collecting system. And apart from that, we also have other additional protocols such as a CT cystography, which we can perform by infusing the contrast through the pre-inserted urinary catheter to assess a urinary bladder injury. We also have special techniques such as a split bolus technique, where we give a contrast injection at different timing and eventually produce one scan where we have a arterial and also venous enhancement. This technique is good in the terms of a reduction in radiation dose. However, it also has its disadvantages, which is if you want to assess a vascular injury, it will be more difficult because it's difficult to differentiate active contrast position versus a pseudoaneurysm. So in conclusion, there's no one protocol that fits all. So going back to this case, sometimes when the patient have a polytrauma, the distracting pain can actually mask the of the background intracranial hemorrhage. So usually in polytrauma case, we will routinely perform a plain CT brain as well as a cervical spine. So in this case, we don't see any acute intracranial bleed and there's no cervical spine fracture. Now I'm showing the CT at a portovenous phase at the level of upper abdomen. So you can see from this scan, the patient actually have the upper limb position over the anterior abdominal wall. So this is sometimes it's kind of like a pitfall because sometimes you just cannot position the arm of the patient in the optimal position. So we have to accept this suboptimal scan, and sometimes it will produce a strict artifact causing a dilemma in diagnosis. So as for this case, you can see there's a faint hypodensity within the spleen. If I put a close up, you can see actually there's a hypodense linear streak within the spleen, which makes us wondering whether it's a true trauma laceration or is it just an artifact. So we'll always counter check with a coronal view, and from a coronal view, you can actually see this one. There's a line, hypodense line, which measure approximately 1.2 centimeter. And at the same time, there's also associated perisplenic hematoma. And on a on a bone window, you can see there's a fracture over the left 10 ribs. So overall, we can presume that the patient actually have an impact over the left side of the upper abdomen, and we strongly believe that this patient actually have a some kind of splenic injury. So based on the American Association of Surgery of Trauma, they actually have a grading for different solid organ injury. So for this patient, the splenic injury actually falls into a grade 2, where he has a parenchymal laceration of less than 3 centimeter. I won't be going to detail in this grading system. Anyone who is interested can actually go to the website to have a look. So subsequently, I'm showing this axial and coronal view. We can see that's the extensive retroperitoneal hematoma actually extending from the pelvis and all the way to the abdomen region. And we also see actually some of the hematomas seen around the paranephric region over the right side. And this is another pitfall in the imaging I would like to share with you is sometimes the patient have a breathing artifact. We have this motion causing a degradation of the images. But for this case, even with the motion artifact, we don't think the patient is suffering from any right renal injury. So on a bone window, you can see this is a most striking findings for this patient. There's a comminuted fracture of the right iliac wing. And also on this view, you can see there's a widening of the left anterior sacroiliac joint. And over anteriorly, the symphysis pubis is disrupted. And there's also a comminuted fracture involving the right superior, left superior pubic rami, left anterior acetabulum, and also right posterior acetabulum. If we move further down, we can see there's also fracture over the left ischium. And this is three different view of a right acetabulum, showing the patient had comminuted acetabular fracture, which involve the anterior and posterior column. So we also have our grading for acetabulum fracture, which is a Judet and Letourneau acetabular fracture classification system. So in this case, we actually have a both column fracture. And for a pelvic ring fracture, we have another classification, which is a Young and Burgess classification. So we can see this for this classification, they actually divide the type of injuries based on the mechanism of the injury. So whether it's a lateral compression, AP compression, vertical shear, or combined. So we can see here, if the patient actually have a unstable pelvic fracture, it's always associated with a vascular injury and also bladder injury. So in our case, the patient actually has a combined fracture for the pelvic ring injury. So you can see this is a 3D reconstruction. The patient actually have a globally unstable fracture. So this is an unstable pelvic fracture. Now I'll be showing the associated finding due to the pelvic fracture. You can see this is at the level of pelvis. The right internal iliac artery actually show contrast extravasation, suggestive of a vascular injury. And also this is a sagittal view at the level of pelvis, showing this is a urinary bladder where we can see a hyperdense material within in keeping with a hematoma. There's also a extensive extraperitoneal hematoma seen here. So we do a complementary CT cystography, and from this study, we actually infuse the contrast through the urinary bladder, and we can demonstrate the extravasation of the contrast from the urinary bladder. So from here, we can see this is a molar tooth sign. So if you can see this one outlined by this blue line, is a molar tooth sign. It's in keeping with an extraperitoneal bladder injury. So if you look at the level of the bladder neck, we can see the contrast extravasation is actually from the bladder neck. So this patient is actually having a bladder neck injury with a extraperitoneal hematoma. So again, going to the ASD bladder injury classification, because this patient have a bladder neck injury, so it actually falls under grade 5 bladder injury. So before I conclude on the CT finding of this patient, I'm just showing a delayed phase of this patient, showing a collecting system over the right side. We can see that there's a narrowing of the upper to mid ureter due to the surrounding hematoma, but otherwise you don't see any contrast extravasation from the upper urinary tract. So overall, in conclusion, for this polytrauma case, the patient is suffering from an unstable pelvic fracture with vascular and urinary bladder neck injury. And at the same time, she also had a grade 2 splenic injury and a left hand rib fracture. I therefore thank you, and thank you for your attention.
Thank you, Dr. Ho. That was a very extensive view of the patient's radiological CT finding. And I think it reflects how severe the patient is. So let's move on to our next speaker. I would like to invite our emergency physician, Dr. Afrizah Abu Bakar, to present her talk.
Thank you, Dr. Khaldun. Let me just share my slide. Okay, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all the audience present. I thank Prof. Khaldun for moderating this session today. I thank my co-speaker, Dr. Shafiq, Dr. Ho, and Mr. Karim in enlightening all of us regarding resuscitation of a polytrauma patient. So as Dr. Shafiq has actually outlined the case, we've got a young man with severe with polytrauma who presented early in the morning to our emergency department. A multidisciplinary approach was done, and alhamdulillah, a good outcome for the patient. So we will be talking about polytrauma. Now, in polytrauma, Adam Cowley mentioned there is a golden hour between life and death. Actually, there is no actual golden hour, but what this highlights is the importance of time, the essence of time in managing a patient with polytrauma, and the global impact of road traffic accident as contributing towards polytrauma is 1.35 people die each year because of road traffic accident, and more than 90% of these cases falls into low or middle income countries like ours. And besides the fatal outcome, 20 to another 50 million additional victims suffer from non-fatal injuries. So the road traffic accident actually contributes towards a large proportion of death in our country, especially among the youngs. Now, when we manage patients with polytrauma, we follow the Atls protocols, okay? So the Atls outlines the principles that we treat the greatest threat to life first. In the initial management, the first couple of minutes or hour, the definitive diagnosis is not immediately important. And it is of utmost importance that we stabilize that patient. We should do no further harm, and we should assess, intervene, reassess, and continue this cycle until we can work out a definitive management for the patient. Okay, so when we assess the patient, we intervene, we will always look back and see whether our intervention works or not, or are we moving the patient back to his normal physiological state. Okay, the approach in ATLS is first we perform primary survey. Dr. Shafiq mentioned that a little bit earlier. And then we, at the same time, we are moving towards resuscitation with the primary survey, adjuncts to primary survey, and then we move to the secondary survey. We usually do not perform secondary survey until we have actually managed or at least get through some of the primary surveys 1, 2, and 3. Now, although it says it's 1, 2, and 3, but most of the time it's done as a multidisciplinary team together. So some will do the primary survey, at the same time resuscitation is ongoing and the adjuncts are being performed. Once we've got the patient to a somehow manageable situation, we move to the secondary survey and to the adjuncts to the primary survey. All the other, whilst this is going, continuous monitoring, re-evaluation, and post-resuscitation care is ongoing. At the same time, teams are trying to figure out the definitive care and trying to plan for a tertiary survey and management. So when we talk about primary survey, first, we actually look, when we receive the patient, it's an immediate response that we look if there's any catastrophic bleeding that we need to attend to immediately. Otherwise, we will always proceed to the airway and cervical immobilization. The breathing, circulation, disability, and exposure completes the ABCDE of the primary survey. Adjuncts are the chest or pelvic X-ray, FAST and E-FAST, most people say tubes or finger in any orifice, okay, the Foley's orogastric or perectal, plus or minus ECG and arterial or venous blood gas. Once this is done, the secondary survey is actually just an examination of the head to toe, going through the different, the patient and looking for injuries that contributes towards the whole trauma management. X-rays or radiological scans like CTs or ultrasound can be ordered based on what is the most likely injuries suspected. Okay, so the approach. once we find the patient, we approach the patient as the systolic blood pressure, the respiratory rate, and the Glasgow Coma Scale. We pay attention to these three parameters first and try to correct the patient's physiological state to as much as possible to near normal. Okay. And then we assess from the physiological point of view, we move towards the anatomical injury that is present on the patient. Okay, penetrating injuries to the head, neck, torso, any flail chest or long bone injury, crushed, degloving or mangled extremities, amputations of limbs, pelvic fractures, open or depressed skull fractures, or any paralysis present. So these are major injuries we look for when we perform the primary surveys. At the same time, when we perform our primary survey, we try to get a little bit of a sample history in assessing the impact of the accident or the injury that will actually contribute towards the patient's outcome. A fall of more than 20 feet or 10 feet in children, high-risk automobile accident or motor vehicle crash, where the patient is ejected out from the vehicle, and intrusion of any particular occupant or any other things, death in same passenger compartment, or vehicle telemetry data consistent showing a high risk of injury. Okay, automobile versus pedestrian or cyclist are considered also a high impact injury. Then we assess whether these patients fall under special consideration, whether they are in the extreme age, at the same time whether the patient arrives in the state of having past medical history of on anticoagulation or having bleeding disorders, a motor vehicle accident or road traffic that has concurrent burn injuries, time-sensitive extremity injuries like open fractures or vascular compromise, patients who are end-stage renal failure, pregnant patients, or in cases where the pre-hospital care or EMS provides judgment saying that this is there is special consideration in this case, such as the patient was entrapped in the car or in the area before the rescue team could actually remove the patient. Okay. Now, when we talk about polytrauma, we cannot forget about the death or the triad of death that contributes towards the patient's increased mortality and morbidity. Now, there's three components of the triad of death. The first is hypothermia. When severe hemorrhage develops, the oxygen delivery to the tissues diminish and causes the body temperature to drop. When this hypothermia develops, there will be increased bleeding by multiple effects on the coagulation cascade, such as platelet adhesions, dysregulating the coagulation factors and enzymes, and it interferes with the fibrinolysis of the coagulation cascade. As more hemorrhage continues, the hypoperfusion causes inadequate tissue perfusion, the production of lactic acidosis, and this contributes towards the acidosis that is apparent in the patient. The acidosis with the hypothermia further reduces myocardial contractility, hence triggering the worsening oxygen delivery to the tissue, hence the cycle continues. Okay, so this is the triad, the death triad in trauma in a figure depicting the severe relationship between one to another. Okay. And a study by Gonzalez actually state that the presence of the lethal triad is associated with higher mortality. And Mitra, with Tulio and Cameron, actually says that none of their patients who were admitted to their ED with the presence of the triad survived to discharge. Okay, so how are we approaching the patient in the emergency department to ensure a favorable outcome? So we approach as a damage control resuscitation, where it is a systemic approach to start from even the pre-hospital care up to the OT and the ICU. It is designed with damage control surgery to promptly and aggressively reverse the lethal triad. And the damage control resuscitation attempts to prevent, okay, but it does not actually treat coagulopathy as the treatable arm of the lethal triad. So what we do is we try to treat all the three components to prevent coagulopathy. And damage control resuscitation involves three phases. First, the control of life-threatening hemorrhage and contamination. It starts from pre-hospital care, continuing to the emergency department and into the OT. A more complete resuscitation and correction of the physiological derangements, usually from the OT to the intensive care unit, and the definitive management of the injuries itself. Okay, so a summary to actually describe what each parts or where things happen in each stage of the patient's presence. So at the point of injury, when the pre-hospital care arrives, what they do is they scoop and run. Okay, they don't stay and play. So scoop and run is actually a versus of stay and play, where they actually bring the patient, try to resuscitate in the ambulance, prevent hypothermia and get the patient to the emergency trauma center. The second point, when they arrive to the emergency department, is we allow for permissive hypotension, keeping the systolic blood pressure around 90 to prevent bursting of the clot or further bleeding because of the high blood pressure. We transfuse blood and blood products, minimize fluid resuscitation, start on the IV tranexamic acid and the blood transfusion protocol. And our goal was to mobilize the patient to OR or the interventional IR suite as quickly as possible. In the OT, they will continue on the permissive hypotension. They will aim to continue on the massive transfusion protocol and perform damage control surgery. Okay, the aim is to control surgical bleeding and to control the contamination of the injuries. Once from the OT, the patient goes into intensive care unit, they reverse the hypothermia, coagulopathy, and acidosis, support the hemodynamics, and continue the resuscitation until a time where the patient is more stable to move back to OT for definitive surgical repair. At the end of it, the patient is aimed to be weaned off from the ventilator, a definitive closure to the abdomen or any other injuries, and to bring the patient back to the normal physiological state. Okay, with that, I thank you.
Thank you, Dr. Afliza. So we already have several questions, but before we go into the question and answer, we finish off with our last segment. We'd like to invite Encik Karim, our pre-hospital care service staff, to talk a bit about the transfer of a critical patient. Encik Karim.
Thank you very much, Dr. Khaldun. Thank you to all the presenters. So I will continue my presentation with the management of the pre-hospital care for transferring this patient. So I would like to share my screen. Okay, I hope all of you can see my screen here. So we continue with our transferring patient, how we transfer this patient. Actually, this is one of the part of the pre-hospital services, is a continuum of care from the incident site or from the house until to the definitive care. So this is some clinical vignette about these cases. The decision made from the physician to transfer this patient to the tertiary hospital for further management. Then we have an unstable patient for the interfacility. What kind of the things that should be prepared before you transfer this patient? So before we go further about the pre-hospital care, we have to see about basically what is a pre-hospital care. Sorry. What is a pre-hospital care? Pre-hospital care is a management to bring the resuscitation room to the roadside or to the home to resuscitate the patient and to bring back patient to the hospital or to get some definitive care. So this is meant by the assistant medical officer in Malaysia and some other countries meant by the paramedics. So this is the continuum of care about the patient regarding patient injury or any medical illness that happen. So if you can see here, this is a part of the discussion today. This is the disposition patient to the other hospital. Before we send the patient, what the most important things we consider before we transfer this patient. So a lot of things you have to consider before the transfer patient, because the risk in transferring patient from one point to one point is quite crucial decision made from the decision. Decision must be made according to the to take all the ecosystem of the transferring process. Oops. Okay, what we need to consider before we transfer patient. We know the critical patient is dynamic and precursor state. During the transportation, patient can be dropped their BP or their oxygenation and other things. So the transfer potentially expose them to additional harm and instability. So during the transportation of this patient, we can create the sum of the other incident within the incident during the transportation. So we have to make clearly to make surely that our decision is more benefit to the patient outcome after we transfer to another hospital. The goal of a critical care transfer should be the maintenance of the high quality care. There is no substandard of care during the interfacility services. So all the paramedics or the AMO are qualified and also he or she able to manage in the confined space in the ambulance. In the ambulance, we have the small space there. So there is nothing we can do during the transfer, but we can manage or minimize the standard. So before we transfer, we have to make sure all this patient was stabilized before the transfer the patient. So moving the patient to appropriate location is in an expedite and safe manner. So it's to make sure patient is safe and also the staff is safe also. So from the study from Malaysia and also from the outside, the most accident is an ambulance during the daytime. So we have to avoid that if we want to transfer, and we have to make clear what is kind of this case we transfer and the benefit to the patient. So this we can see from the some definition about the transfer option in the pre-hospital setting. The first one is the primary transfer. What do you mean by primary transfer? Is the from the cases we respond to the patient, like this case, and then we send to the receiving hospital. Currently, we have some sort of a good coordination between others in the hospital in the Klang Valley, also in the other state. So we have the patient have to call, or the victim or the bystander have to call 999, and then the ambulance can go to the incident sites. And that one is the primary transfer, meaning that is a call from the 999, and the ambulance come to the incident site. After that, the patient will send to the receiving hospital. And then a standard primary transfer is one of the good service from, actually it's not practiced in our country yet. It's a practice from the other country. They can transfer this patient to the trauma center straightly to the trauma center bypassing the nearest hospital. This is one of the good continuum of care from the pre-hospital care to the hospital. This is also applied when we have some cases like this. This is a quite polytrauma cases. We cannot send this patient to the district hospital. We have to bypass, and the hospital will accept these cases because we have some rule and guideline to this kind of cases. So what is the secondary transfer? Is from the hospital, the facility that have the good services that they can give to the patient. So this is the issue we are discussing for today. This is one of the part of the secondary transfer. Okay. And then the repartition, when patient will have to manage, then we send back to the nearest address. This one is we call the repartition transfer, and the number 5 is about the transfer. This is the case is with the discussion is about the transferring patient between the hospital to the hospital. So we have some good communication with the receiving hospital regarding these cases, because this is a quite ill patient and they have some risk during the transportation. Intra-hospital is about the transfer the patient within the hospital compartment, such as from HCTM to the HPAK. So clinical transfer from the specialty treatment or investigation not provided for referring hospital. They send for just for the clinical process only to get some secondary opinion or to get some equipment or things that can be improve their decision or the diagnosis. And the capacity transfer was for specialist treatment for investigation normally provide at a referring hospital, but which is not currently available. And the last one is transfer capacity. So sometimes we don't have some capacity, then we should transfer these patients. So according to this case, we do a inter-facility transfer, which is between the hospital to another hospital. Okay, this is a transfer process for the transferring patient. If you become a physician, this is the common things you have to think. There is a 6 step in here. So identify the need of transfer. What is the benefit of the transfer? What is the risk if we transfer the patient? What is the route we can use? What is the type of transportation we use? Either from air, land ambulance or ambulance. The agreement is quite important. This is very important part that you have to must be agreed with the hospital, another hospital to receive the patient. Okay, and then the third one is how the process handover from the critical care staff to the transport team. This must be clear because during the transportation and route to the transportation, there is some changes of the vital sign of the patient have to be spelled out to the receiving team, and the transfer between care facility. What they have, what is they can do this for this patient. What happened to our hospital? What we have lack of the facility that we have. That is the most important for the transport patient. And handover from the transport team to the acceptance team. There's 2 different things handover. One is from the critical care staff, and another one is the transport team to the acceptance team. Okay, then return transport team to the adequate to the base. This is the common that we have to think about before we transfer the patient. And this is some interfacility algorithm that take from the primary management of polytrauma. So this is a guideline you can see from here. Then this is the decision making of the when we want to transfer this patient. What is the benefit of the transfer patient? What is the risk of the transfer the patient? And also what is the most convenient transport for the transfer the patient? So procedure and protocol. So decision must be made from the senior doctors or senior physician or specialist or consultant in charge of the patient weighing the risk and benefit of the transferring. And the decision must be communicated to the next of kin where applicable. Some studies say there is frustrated from the next of kin because they are not informed about the transferring process. And the communication should be not sustain or compromise the clinical management of the patient. So this is important things that have to remember to the physician that before they transfer the patient, this is the step you should follow before transfer the patient. Okay, right. So then next, for the decision making for the transport, we have the 3 types of the transportation from route, rotary wing, or medical or fixed wing. This is quite the differentiate to you. You can see what kind of the transport can be used. So for these cases, hospital Tunku Jaafar is not far from here. It's about 100 kilometers. Then we can use the road. But if you want to do a rotary wing, this is not a possibility because there are some procedures have to be taken. So this is one quite of view that you can see where you can decide whether you want to use a road or the air transportation. Of course, the cost is very low for the ambulance, but there is a quite high risk there. Okay, responsibility. Who is the responsibility of the during the inter-facility transfer? There must be clear throughout the transport. Okay, so the receiving parties or the AMO or the nurses or the accompanying doctors must be clear about the cases. All right, and then he or she must be clear during the en route what happened to the patient and what is the mitigation plan if the happen to the patient. Is any communication part that can be communicated with the other hospital nearest in the on the way and in en route can be called before if the patient have something happen if the vital sign is dropped or patient is deteriorate or patient unconscious. The most qualified medical practitioner should be responsible for the transport process. The most qualified medical practitioner should be responsible for the transport process. This is very important. Before we transfer the patient, the medical practitioner have to know about the consequences of the transfer process. The pre-transport resuscitation and stability is a joint responsibility of both referring and receiving facilities. So this is one of the issue that we have to make sure the communication between the both parties is a continuity. Agreement between the referring receiving facilities must be achieved on the emergency care and the level of stability prior to commence the transport. So to make sure patient will stabilize, then we can transfer. This is a quite interesting polytrauma patient we transfer. There's a lot of things we have to think about this kind of a polytrauma patient. Yeah. Care of patient and safety during transport and responsibility of the referring. That, and we have to. This is one of the responsibility. Upon arrival, the continuity of care is responsibility for the receiving facility after the complication and handover. Handover should be done between medical personnel of the same or the high level. We cannot pass over to other people. So if the escort team is from the doctor, so the doctor have to find the doctors between the doctor to transfer to pass over these cases. You cannot pass over to the AMO or others. So a quick assessment before we transfer the patient, we have to see the escort people, the transfer team have to see this to make sure airway, breathing, circulation be secured and be patency. Then we can transfer. So for example, airway must be secure and patent, adequate respiratory, viable, appropriate, PIT, CPAP or F4 level is correct before we transfer. And so you see from the circulation before the transfer, hemorrhage is stable, vital sign is displayed, and the transport meter clearly visible to the transport team. All right. Okay. Then we see from the venous access, adequate and secure pattern. Then we must make sure the packaging is very clear to see all the IV line and the medication are already prepared before we send the patient. Yeah? And last is safely secured on the trolley. All right. Okay. This is one of the common accident happen when patient is not securely secured in the trolley. Patient will draw up from the ambulance. And then pre-departure process, transport team must be free from the duties of open activation. So we have to find other people that are free, they are not working today, then we can do the transportation. Even though this is about a 1 or 2 hours process transportation. The receiving person or staff at the destination must be notified. So we can use our system, current system, to communicate with the hospital HTJ to inform the patient will be transferred, and the ETA or the estimated time of arrival from our dispatch center to the HTJ dispatch center. And then make sure that the arrival time is clearly understood. All right. And also all pieces of the equipment must be checked. Check the oxygen, check the equipment, the battery, and address and notes that the imaging film gathering and use the checklist method. So we have supposed to have some checklist method before we transfer this patient to another hospital. So these are the common things you have to do is to check your oxygen. This is some calculation you have to remember before you transfer the patient. For this patient, it takes about 1 to 1.5 hours. So how many oxygen tank you want to bring to the in the ambulance? So this is the formula you can use before you transfer the patient. If patient use a lot of oxygen, of course this is patient intubated, so you have to use a lot of oxygen. So care of during transport, act immediately. Any change of the patient must be correct back. An expected event or critical incident. So should be seen during the transportation until patient arrive at the hospital. If anything happen, we can stop the ambulance and then we see the patient condition after that, or we can seek any treatment from the nearest clinic en route off to the STJ. All right. Then arrival procedure, transfer designated area. So of course, during when we arrive at the hospital, we go to the ED and then we transfer at the designated area and hand over to the clinical done, and to pass over anything happen during en route. Yeah, must be clear. All right. Then the transport staff must be remain with the patient until appropriate handover has been done. So for the transfer of this patient, cervical spine immobilization must be in situ, and patient must be put under cervical spine, and pelvic and long bone fracture must be immobilized. All the drain lines should be strictly fixed before we transfer. Inter-hospital transfer on the spinal cord or stretcher is inappropriate because we can get sore during the transporting, especially when this take a long hours to transfer the patient. Okay, we already discussed about the hypothermia during the patient, so ensure the covering all the space of the patient. So we have to wrap with the to make sure we don't want to prevent the heat loss and preserve the heat. Vacuumators can be used. Blankets, bubble wraps, and active warming are used during the transportation. Yeah, continuous temperature monitoring is recommended during the transportation. So we have to see the temperature of the patient during the transfer. Yeah, and then the transfer patient packaging is carefully packaging should be minimized movement of heat loss, nagging, and the injury during the transfer. This is quite important before we transfer the patient. Creases or clinical debris in sheet should be avoided to reduce the pressure of areas. So this we know this is a motor vehicle accident. So this kind of thing we have to clear to make sure the patient not get any secondary incident within the incident before we transfer the patient. Patient must be clearly and clean thoroughly before we transfer the patient. Transfer trolleys must be fit securely into the vehicle to protect patient and the transportee in case of an accident. And then trauma patient packaging, the patient must be re-accessed at all time, all steps of movement after loading or before patient put in the ambulance. Follow the checklist that are designated, then just follow and then according to the systematic check. Open satisfactory, then we send patient to the hospital that are designated. Okay, this is a sum of the risk of the interventions that you should be known. One is that we divide into three components, which is a medical, technical, and human errors. Okay, then this is common for the cardiac arrest, hypotension, arrhythmia, hypoxemia, pneumothorax are the medical, the risk of the medical. For the technical, electrical outage. So we bring a lot of things, medical equipment, biomedical equipment. So we have to make sure the battery capacity is not failure. So we have to bring some additional battery or additional, or we can see the ambulance capability of the support the electricity to the biomedical equipment. So human error, medication error, of course. Before we transfer, we have to do to shrink out all the medication and label it. So we don't shrink out during the moving of patient because we can create injury to the staff. Yeah. And this is a tip to remember before we transfer this patient. The accept model, assessment of the patient thoroughly from head to toe before we transfer, and the control, how we control the patient, we control the management inside the ambulance, outside the ambulance, and transfer it. And communication must be created between the receiving hospital and the sending hospital, and evaluation process thoroughly before and during and after the receiving hospital, and then preparation and packaging to the patient must be clear because we want to reduce the hypothermia patient for this kind of patient. And a transport decision, what is kind of transport decision that we can use for this kind of patient. And conclusion, the limitation of vehicle being used, there is a common things we have to think about before we transfer, and also benefit of the patient transport. The mode of transport of patient, we have to choose according to locality and according to the cost of the transferring. The effect of the mode of transport on the medical equipment used during transit. Then we have to see the vibration of the ambulance, vibration of fixed wing or rotor wing must be clear in this before we bring the all the equipment. And the effect of the mode of transport limiting possible medical intervention, and the point is correct patient packaging, handling, and loading is must the common things that we should have a thing before we transfer the patient. And lastly is about the benefit of transportation, even either because of we don't have some specialty, then we transfer, but we have to consider about the benefit of the patient and also benefit of the staff during the transportation process. This is some reference. With that, thank you. I'll pass over to the Prof. Khaldun. Thank you very much.
Thank you, Encik Karim. That was a very concise presentation about transport patient, about the rotor wing especially. You need to weigh every equipment, every patient as well, because it will affect how the dynamics of the transport. Okay, so we have 1 or 2 minutes for question and answer. There were several questions already answered by Dr. Afiza. Just one question to Dr. Shafiq. Does this patient have pneumothorax, and what can explain the missing sliding sign?
Thank you, Prof. Khaldun. For the missing sliding sign, the patient initially have missing sliding sign because absent sliding sign is a true negative for pneumothorax, basically. And you can only rule out by observing lung point, which is in this case is quite difficult because we could not turn the patient back to perform a lung ultrasound on the back because it's very painful even to lock roll the patient. But but the other modalities, which is we done the CT thorax and chest X-ray, does not show any pneumothorax.
Okay, so that is found by other modes of radiological finding lah. Okay, maybe Dr. Ho, just one question. How would you consider if this patient becomes deteriorated during the process? I know this is already in the secondary survey where patient is sent for CT scan. But let's say in the CT scan, I know some centers, they have CT scan facility in the emergency department itself, different from our setting. So how do you consider the risk of having this patient doing CT in your department?
Just like I showed in the guideline, just like the European Society guideline, they actually did discuss about having a CT scan in the ED department, actually to facilitate for patient transfer, especially in those patients who is hemodynamically unstable. So in our case, usually because you still need to travel from the ED department to our department, so most of the time we'll inquire about the condition of the patient. We want to make sure that the patient actually is stable for transfer before we accept the case. If the patient unfortunately deteriorate in our department, usually I think when they send the patient, the ED will come together with their team, including the MA, also the medical officer. So resuscitation can be.
So the resuscitation commences in the radiology department itself. Okay. Maybe the last two questions for Dr. Afrizah to summarize. One, why was this patient transferred? And the other one, what about tranexamic acid and the MTP protocol?
Okay, I've answered that, but I will just summarize my answer. Tranexamic acid in the phase of polytrauma is given based on the CRASH-2 trial. It finds a favorable outcome where reduction of mortality is reduced by 1.5% in 28 days. Therefore, we practice giving that, however, only in adult patients. Okay, it's not proven yet in children. Regarding the transfer of this particular case, well, by the time the patient was stabilized after about 2 to 3 hours, all the parameters improve after we repeat the blood samples again by the end of the shift, which is about 8 hours. At that particular point of time, because of the stability of the patient, orthopedic surgery, the multidisciplinary discussion, we find that the complexity of the pelvic fracture, the orthopedic advised that maybe a surgery in another center where costing has to be considered in to say in this particular patient will be better. And as the family agreed upon the transfer and the patient was stabilized, we prepared all the bloods and everything ready before transfer. So Alhamdulillah, the patient was accompanied by one of the surgical medical officers with the pre-hospital care team and transferred to Tuan Jafar.
Okay, thank you so much. I think that's all the time we have for this morning. So we'll proceed next to the Kahoot session. I would like to invite our technical team to proceed with the Kahoot session. Thank you, everybody.
Thank you.
Thank you, Prof. Khaldun.
Thank you, everyone.
Thank you, everyone. Thank you, Prof.
Okay, do we have any QR code? Okay, everybody can scan your QR code for the MMA. Okay, terima kasih semua. Thank you so much. And see you at the next CPC. Take care.
Terima kasih, Prof.
Okay, terima kasih. Thank you all everyone, Dr. Ho, Prof. Kal, Syafiq, Cik Karim, Cik Bukhari, Puan Mira. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Isi dulu link semua isi dulu link kehadiran Terima kasih.
Kejap link.
Okay.
Attendance. Okay.
The link kehadiran is in the chat, right?
Ya, betul.
Okay, please fill in the attendance link.